Sir, the Department of Anesthesia at St. John's Medical College. He is an alumnus of Vijayanagara Institute of Medical College. Over to you, Dr. Vikram. I think you can share your screen.
Yes, sir.
Yeah.
Very good evening to all my respected teachers, seniors, colleagues, and friends. So the topic for today's academic session is anesthetic considerations in interventional neuroradiology. So as we are all aware, the subspecialty of interventional neuroradiology has grown dramatically, and the spectrum of cases is also rapidly expanding. The procedures that were previously untreatable or only possible with open procedures now can be approached through intervention neuroradiology. And so these procedures are also referred to as closed head neurosurgery, and a more appropriate term would be endovascular neurosurgery. So before I move into the topic, this is our experience. These were the cases that were done here in our center at St. John's Hospital in the year 2020. So most of them were diagnostic procedures, cerebral angiogram, and the intervention procedures mainly included acute stroke, aneurysm coiling, carotid stentings, angioplasties, and embolizations. And I'm sure with in the coming days, more and more centers will have this neuroradiology suites, and these procedures will be performed frequently. And anesthetist remains an integral part of this team, and it's important that the anesthetist become familiar with these procedures and the challenges faced in this procedures. So these procedures are performed in INR suites, which are specially designated for such kind of procedures, and these are situated away from main OT complex. And just like any other procedure that is being done outside OT, here also we have to face certain challenges, like there's no immediate assistance available, there's lack of equipments, and there's limited access to the patient. This is our INR suite. As you can see here, the patient, there's a very poor access to the patient. On the head end side, there is a image intensifier, and the radiologist stands on the right side of the patient, and on the left side, you can see a large screen, and there are monitors near the leg end. So the access to the patient is limited. So apart from these general considerations, there are certain things that are unique to these procedures. The neuro-intervention radiology procedures are complex and time-consuming. The patients who present for the procedures are they belong to high-risk group, and you have to keep in mind about the neuroprotective measures. And these procedures are associated with a lot of hemodynamic alterations, and the radiation exposure is significantly high. So coming to the indications, so this can be broadly classified into diagnostic and therapeutic. The diagnostic mainly is the cerebral angiogram, and the therapeutic intervention, the list is big. Just to name a few, embolization, commonly performed procedures include embolization of aneurysms, arteriovenous malformations, carotid cavernous fistulas, intracranial tumors, and stentings to carotid and vertebral artery, thrombolysis and thrombectomy after stroke, balloon angioplasties, sclerotherapies for angiomas, treatment of cerebral vasospasm, and carotid artery balloon test occlusion, and intracerebral chemotherapy for tumors. So these procedures can be posted either as elective or as emergency. So whenever there is a time for elective cases, the patient should be evaluated properly, look into the comorbidities and the medication history. A special emphasis should be given to cardiovascular system, because there can be a lot of hemodynamic fluctuations during the procedures, and patients with renal dysfunction are at high risk of developing contrast-induced nephropathy. And a detailed history should be taken with regards to allergies, because the contrast that are used during these procedures, some patients are prone to develop adverse reactions. And of course, the CNS examination should include a complete baseline ECS, high mental functions, and look for neurological deficits. For elective cases, for the standard guidelines and pre-medication, like any other cases, you can use proton pump inhibitors and anxiolytics, but be careful when you're using pre-medication in patients with altered sensorium. So coming to choice of anesthesia, various factors need to be considered before you decide on the type of anesthesia. So these factors include mainly the procedure that's being carried out, and the need for neurological assessment when the procedure is being done. And you have to consider the patient comorbidities, and comfort level of the patient and experience of the neuro-radiologist also matters. So these procedures can be accomplished either with under local anesthesia, conscious sedation, or general anesthesia. So irrespective of the anesthesia technique that you choose, the goals remain the same. That is to safely render a patient immobile, painless, and comfortable during the procedure, provide the neuroradiologist with optimum hemodynamic and intracerebral conditions, allow for pre-operative evaluation of neurological functions, and to assist in treating complications, if any, during the procedure. So local anesthesia is most often used for diagnostic angiography. Here, a femoral sheath is placed under local anesthesia by the intervention radiologist, and sometimes minimal sedation might be required in anxious patients. Conscious sedation can be used for a lot of procedures. The main advantages being it's very easy to perform neurological assessment during the procedure, and there are no hemodynamic changes associated, unlike GA. But there are potential disadvantages associated with this, the main being poor control of the airway and potential for hypoxia, hypercapnia, and labored breathing and movement. And there is a risk of aspiration, and patients sometimes can become dysphoric, and there can be prolonged somnolence, and vagal reactions are also a possibility. And the biggest disadvantage is the need to interrupt the procedure and induce general anesthesia if the patient is unable to tolerate sedation. So some of the procedures that can be performed under this monitored anesthesia care include carotid stenting, carotid occlusion test, diagnostic angiography in uncooperative patients, intraarterial chemotherapy, preoperative embolizations of tumors, embolization of AV malformations, and coming to general anesthesia, this is the technique of choice whenever the procedure is a complex, prolonged one, and where absolute immobility is a criteria. And one such procedure is aneurysm coiling. The advantages of general anesthesia includes a better control over the hemodynamics, carbon dioxide levels, and ICP, and respiratory immobility and Valsalva manner, if the radiologist requests for it, they are possible only under general anesthesia. And neurological emergencies can be dealt better when patient is under general anesthesia. But the disadvantages include the sympathetic response resulting in undesirable hemodynamic changes during intubation and during emergence. And the other disadvantages is neurological assessment is not possible during the procedure. And the role of LMA for these INR procedures, our experience is limited, but there are certain reservations, like there's always risk of displacement, and reinserting LMA might be difficult since the access to airway is not good. And the other disadvantages, the patient can move and they can be labored breathing in lighter planes of anesthesia, and hypercapnia is other disadvantage, especially when patient is spontaneously breathing and is in deeper planes of anesthesia. but still LMA is a possibility. Only thing, we have to choose the patient wisely. And before inducing a patient, make sure all the essential equipment, including the infusion pumps, the syringes with extension, pressure bags, transducers to set an arterial line, and all the anesthetic medications are available. And apart from this, keep ready the emergency drugs, including atropine, adrenaline, in case of any complication. And since there are a lot of hemodynamic fluctuations, we also need to keep ready the vasopressors, mainly noradrenaline, phenylephrine, and antihypertensive agents like injection labetalol. So they cannot be compromised on monitoring. Use standard monitors that includes ECG, pulse oximetry, NIBP, and ETCO2. Invasive BP monitoring is essential in most of these procedures, as I've already mentioned. The procedures per se can be associated with fluctuations, and sometimes the radiologist can request to raise the pressure or lower the pressures. So when you have an artery line, it's easy to titrate your drugs. And when there are any complications, it can be better managed when you have an arterial line in place. And this can be used for post-procedure monitoring, and also to draw samples to look for ABG analysis and monitoring activated clotting time. So generally, it's the left radial artery that is readily accessible to us. So most of the times, arterial line is secured in this left radial artery. So the radiologist inserts this introducer sheath into the right femoral artery, generally uses a 5 French or a 7 French, depending on whether it's a diagnostic or a therapeutic procedure. And as you can see here in the picture, it has a side port and it has a stopcock in the end. Even this can be used for monitoring arterial pressures. But sometimes when a large guide wire is inserted, there may not be a good backflow during the procedure, and the readings are not always accurate. So it's always better to place a separate arterial line just exclusively for monitoring. So in case if you have a difficulty in threading an artery with a cannula, we have an easy option here. That is an arterial catheter that comes with a needle and a guide wire, which can be, arterial line can be easily secured by using Seldinger technique. Coming to conduct of anesthesia, conscious sedation can be managed with short-acting opioids and benzodiazepines combined with an antiemetic. And general anesthesia, I'll not go into details of what drugs to use, how to induce. Just ensure smooth induction with minimal airway manipulation to minimize the hemodynamic changes. And these procedures generally are not painful, so avoid long-acting opioids. And maintenance is with combination of air, oxygen, inhalational agents. Don't use a very high concentration of inhalational agents. You can go up to MAC of 1. In case if you have to deepen the plane of anesthesia, you can always go for propofol infusions or dexmedetomidine infusions. And avoid nitrous oxide, because air bubbles can enter into the arterial circulation when a sheath is placed or a guide wire or microcatheters are being introduced through the sheath. And for major procedures, it's better to have 2 wide bore cannulas. So one cannula you can use for vasopressors and vasodilators, and use long IV extension with stopcock valves, and secure the lines and the circuits properly, and sort them out so that they don't get entangled, especially when the table and the C-arm keeps moving. And it's important to keep patient warm, especially when they're under sedation, because if a patient shivers, there can be a lot of motion artifacts. So you can use fluid warmers and convection warming devices, blankets, to keep the patient warm. And in prolonged procedures, it's also better to catheterize these patients, because again, patients can get restless with full bladder. And in the end, it's important that you do a smooth extubation, and a smooth and rapid emergency will help in facilitating a quick neurological examination. Coming to the other considerations, anticoagulation used in all of these patients. The catheters and guide wires that are used during the procedures, they're all thrombogenic. So all patients receive heparin in a dose of 70 to 100 units per kg, unfractionated heparin, except for stroke patients where there's risk of hemorrhagic transformation, a smaller dose is used. And the activated clotting time is maintained 2 to 3 times the baseline value. And repeat activated clotting time and additional doses of heparin can be given in case of prolonged procedures. And with respect to contrast, we have two main concerns. One is allergic reactions and the other one is contrast-induced nephropathy. So now most of the centers are using non-ionic agents which are associated with lower incidence of reactions. And the risk factors during pre-anesthetic checkup try to elicit history of allergy to seafood or povidone iodine if patient has been exposed to it earlier. Then other risk factors include patients with asthma and thyroid disorders and elderly females. You can consider pre-medication with steroids and antihistamines if there's a strong history of allergy. The second concern with regards to contrast is contrast-induced nephropathy. So the contrast agents are hyperosmolar due to the presence of iodine. Osmolarity can be as high as 600 milliosmolol. Plus, these patients will be on mannitol, and so this makes the patient prone for acute kidney injury in this period. So make sure that patients are adequately hydrated during the procedures, and post-procedures monitor the renal function for the next 72 hours. And patients can be started on N-acetylcysteine, especially those patients with renal insufficiency who are prone to develop acute kidney injury. And the next big concern is the radiation safety. These procedures are associated with a high radiation exposure and interventional cerebral angiogram. The exposure can be as high as 7 to 10 millisievert units. So that's equal to nearly 300 to 500 chest X-rays. So make sure to wear your lead aprons, thyroid shield, and try to stay as far as possible, not only from the radiation source, but also the patient, because the patient is the main source of scattered radiations. And we know that radiation exposure follows the rule of inverse proportion. That is, the exposure decreases proportional to the square of distance from the source. So stand as much as possible, try to stand away from the patient and the radiation source. And if possible, try to monitor from console. As you can see here, you can stay inside the console room and you can monitor the patient. And especially when a CT scan, when a CT brain is being performed, multiple films will be taken in quick succession. And during this phase, the radiation exposure is quite high. So the neuro-radiologist generally alerts the personnel inside the suite to move out when a CT brain is being performed. So coming to the few commonly performed procedures in the INR suite, these include cerebral angiogram. So a cerebral angiogram has a high diagnostic accuracy as compared to CT angio and MR angiograms. And most of the cases, local anesthesia suffices, and patient should be instructed to lie still in order to obtain good quality images. Patient in altered sensorium may benefit from conscious sedation. Coming to the next important therapeutic intervention that's commonly performed is the aneurysm coiling. So here the procedure involves obliteration of aneurysmal sac using coils with or without stents. So flow diverting stent is sometimes placed to reduce the flow within the aneurysm and to prevent the coil from getting dislodged into the parent vessel. So here general anesthesia is preferred because absolute immobility is required when the coil is being deployed. Patient sometimes can develop vasospasm during the procedures, and we might have to start these patients on nimodipine infusion in a dose of 1 milligram per hour. So the preparation is available as 0.02%, that is 10 milligram in 50 ml. You can load it without dilution in a 50 ml syringe and run it at 5 ml per hour. In case there is hypotension, the dose can be reduced to 2.5 ml per hour. But if the vasospasm is persistent and if the pressures are holding, the dose can be increased to 7.5 ml. And it's important to maintain higher pressures around 140 to 160 of systolic blood pressure once the aneurysm is secure. And for this, you might have to start them on vasopressors. And now the management of vasospasm has moved on from triple H therapy to hypertension and euvolemia. It's sufficient if you maintain euvolemia, and you don't really have to overload these patients with fluids. The next procedure commonly performed is carotid stenting. These procedures are performed under conscious sedation because we need to monitor them during the procedure. So deployment of the stent can cause sympathetic stimulation. We observe this very frequently. That results in bradycardia and hypotension. That's because of this. Once a stent is placed, there can be this activation of the stretch receptors and resulting in parasympathetic stimulation. And many times we have to start these patients on vasopressors after the procedures. But you have to keep in mind one rare entity that is possible is hyperperfusion syndrome. So although this is very rare, but still possible. So when there is a stenosis, the cerebral autoregulation is altered. So when suddenly the obstruction is relieved, there can be increased perfusion to the brain, and this can result in intracranial bleed. So patient can present with seizures, headache, and accelerated hypertension. So the treatment mainly consists of antihypertensive therapy and seizure prophylaxis. And one emergency procedure performed in this neuro-radiology suite is acute ischemic stroke. This is an emergency procedure because the intervention has to be carried at the earliest. The intra-arterial thrombolysis has to be done within 6 hours and thrombectomy within 8 hours of onset of neurological symptoms. It can be done both under general anesthesia and MAC, but GA is preferred because you don't want to lose the valuable time. So it involves cerebral angiography to localize the occluding clot, navigation of a microcatheter, and injection of intra-arterial thrombolytics. Commonly used is tissue plasminogen activator. So this may be combined with mechanical clot removal and with or without transluminal angioplasty and stentings. Here again, higher arterial pressures are preferred to maintain perfusion to the ischemic areas of the brain. Early extubation is preferred so that you can do a quick neurological assessment. Embolization of arteriovenous malformation is other commonly performed procedure. It has a high success rate when it's performed by endovascular approach. General anesthesia is preferred again for better visualization. So the procedure involves glue embolization of fistula and feeding arteries. So a fast setting embolic materials or coil is injected in the nidus of the lesion, the AV malformation. And post-procedure again, keep pressures low, maintain mean arterial pressures 20% below the baseline to avoid the risk of bleeding. And steroids can be administered to reduce the perilesional edema. The next is this procedure is not so commonly performed. This is the carotid occlusion test, but it's quite challenging for anesthetists. This is one test where general anesthesia is contraindicated. So this is a test where you look for adequacy of cerebrovascular collateral circulation before electing to occlude the carotid artery during surgery for tumors involving the internal carotid artery. Here, the patient must be awake for the procedure so that you can do a continuous neurological evaluation. So this procedure is often combined with controlled hypotension because it increases the predictive value of the test. So you have to keep the pressures 10 to 20% of the baseline. And the most common complications include bradycardia, hypertension, and loss of consciousness. Plus, these patients have large tumors. Recently, we had a case where a patient was referred from outside hospital with a large tumor involving the mandible, And we were called just for monitoring and to reduce his pressures. So a large tumor, restricted mouth opening or restricted neck extension, this is an additional challenge, and we must be ready to deal with it. Coming to the complications, they can be procedure-related complications, could be hemorrhagic complications or thromboembolic complications. Hemorrhage can result from aneurysm perforation, intracranial vessel injuries, and dissection of the vessel, and thromboembolic complications because of the displacement of coil in parent vessels or coil fractures and vasospasm. And the other non-CNS complications include contrast reactions and contrast nephropathy, which I've already discussed. And complications related to the femoral sheath, they can be hemorrhage and groin hematoma and retroperitoneal hematoma. So what's the role of anesthetist in hemorrhagic complications? You might have to, if a patient has received heparin, you have to immediately reverse this heparin by administering protamine, the dose being 1 milligram for each 100 units of heparin administered. And you have to lower the pressures by starting IV antihypertensives like epitalol infusions to reduce the bleeding, and maintain carbon dioxide in the lower limits, and start anti-edema measures to bring down the edema. In thromboembolic complications, the pressures have to be kept on a higher side so that it increases the collateral blood flow, and also try to maintain normocardia. Thrombus can be dealt by the radiologist by injecting intraarterial thrombolytics and antiplatelets, and malpositioned coils can be removed by endovascular retrieval. So coming to the post-procedure, the decision should be made after discussion with the radiologist as to whether the patient has to be extubated or electively ventilated. Even if a patient is extubated, they are generally shifted to a high dependency unit for neuromonitoring and hemodynamic monitoring. And you should also take, sometimes the femoral sheath is left in place when the activated clotting time is high, and you have to remove this femoral sheath. You have to be careful, give adequate compression for 20 to 30 minutes, and watch for hematoma, and monitor distal pulses. And a close GCS monitoring, neuromonitoring is very important in case if there's any worsening like drop in GCS or a new onset of neurological deficits or anisocoria, you have to alert the neuro-radiologists, neurosurgeons, and further steps have to be taken. So to conclude, the scope of interventional neuroradiology has expanded rapidly, and these procedures pose many new and interesting challenges for anesthetists. Proper communication and coordination between neuroradiologist and anesthesiologist is vital for smooth and safe conduct of these procedures. These are the references. Thank you.
Excellent presentation, Vikram. Sir, Bhaskar sir, whether we'll take the questions now or at the end, sir?
We can take the questions now. We'll be continuity. Yeah. We'll take the questions.
Okay. Yeah, anybody interested who has some doubts, I think you can ask Vikram. Vikram is ready to answer.
Were there any major complications in that list you had given in your data?
No, sir. No, sir. We didn't have any major complications. Like no hemorrhagic complication or thromboembolic complication. But some of the aneurysm patients, they had to be taken for this one. They had vasospasm in the post-operative period, and they were taken back to the to the radiology suite for intraarterial nimodipine injections and all. Apart from that, we haven't noticed any major complications, sir.
Then we have a role beyond in the post-op period, because or do they take care of the whole management in the post-operative period?
So generally here in our center, in our hospital, the patients are shifted to surgical ICU. So we take care of these patients.
You are also in charge of surgical ICU, no?
Yes, sir. I also work in surgical ICU. So actually, I was not involved in any of these anesthesia procedures in this one. I get to see most of these patients in the post-procedure period when they get shifted to surgical ICU for post-op monitoring. That is where I get to see these patients.
Okay.
Excellent lecture, Vikram. It was very informative, actually.
Thank you, sir.
We do a lot of these neurointerventional procedures in our hospital. The only thing what I have found is many of these patients are really challenging for anesthesia, especially they have been brought as an emergency many times, especially the stroke patient.
Yes, sir.
And assessment would not have been done properly because there won't be much time. Full stomach, multiple comorbidities and multiple drug therapies. So real challenging. And the other thing is the prolonged procedures.
Yes, sir.
So it takes hours. I have seen our interventional neuroradiologist goes for some coffee, tea in between. She comes and the anesthesiologist has to be there. The postgraduates have to be there continuously, and many times you may have to give GA also.
Yes,
and
sir, yes.
Many times the patients have been brought directly from ICU to the cath lab, and then the procedures are being done. So real challenge for the anesthesiologist, and in detail you have done very nice lecture. Thank you, Vikram. Thank you.
Thank you, sir. Thank you.
Hi, Vikram. Thanks for the presentation. It was very nice.
Thank you.
I used to work in MAS before, so brought back all those memories. Just whatever. I mean, when I was working before, what the major problem we used to feel was the hypothermia. So because of the prolonged procedure, temperature management was a big problem then. I mean, is anything changed? Do you use anything?
Yes, we have that. I just mentioned in my this one. We have these bear huggers. Bear huggers are nothing but forced air warmers, the convection warmers with blankets.
Okay.
So this is a very effective way to keep the patient warm.
Most of the time, the radiologists, they want access from like from the groin till the head. So do they still allow you to use the bear huggers?
Yes, we do use.
Okay. Another thing was, do you use any monitoring for all of this, like neuro monitoring, anything?
No. As of now, we are not using any neuro monitors.
Okay. Okay. Thanks a lot.
Okay.
Hi, Vikram. Good evening.
Hi, Balakrishna. Hi, good evening.
Nice lecture. Sorry I joined late, but I presume that whatever you do is fantastic.
Oh, thank you, Balakrishna.
Nice to see you after a long time. I just had a small question. Which is better according to you, either TIVA or inhalation when you give GA for all your neuroendovascular procedures?
Our experience with TIVA is limited. So generally, we prefer to use inhalational anesthetics. So as I mentioned earlier, we use up to 1 mag. But in case if you really want to keep the patient deep, then we start the propofol infusions. Other problem with the inhalational agents is we don't have the gas monitors. That the anesthesia station that we have in this INR suite doesn't have these gas monitors. So it becomes we don't use very high concentration of volatile anesthetics. Instead of that, we start propofol infusions.
Do you extubate all your patients?
Very crude method. Yes.
Yeah.
Yes.
Do you extubate all your patients at the end, or you keep them on ventilator?
No. The decision is made after discussion with the intervention neuro-radiologist.
Okay.
So generally, a patient who comes intubated goes back on ventilator.
Okay.
Okay. A patient who comes with a borderline GCS of 9-10, a decision is made only after discussion with the neuro-radiologist. And then we decide whether to electively ventilate or extubate them.
Thank you.
Generally, to be on safer side, patients with borderline GCS, we shift them on tube for elective ventilation, and they're extubated the next day after doing the CT brain.
Thank you.
Thank you.
Any more questions? Yeah. So I think we'll go to the next lecture. Yeah. So thank you, Vikram, for your very good lecture and
Thank you, sir.
comprehensive one.
Thank you, sir.
Comprehensive one. So we have the next lecture by Dr. Mohammad Nizamuddin, who is Assistant Professor at Department of Anesthesia and Critical Care at VIMS Bellary. He will be talking on non-operating room anesthesia. Dr. Nizam, you are there?
Yes, sir. Yes, sir, I'm here.
Yeah.
Am I
Share
audible?
your screen and yeah, you are audible. Share your screen and start your lecture.
Yeah. Good evening, everybody.
You have to share your screen, sir.
Yeah, yes.
Yeah, it's seen. You can go to the first slide and there's a slide.
Yes, sir. So, good evening, all my teachers, my friends, and my juniors. My name is Dr. Mohammad Nizamuddin, as told already. I'm Assistant Professor in Department of Anesthesia. Today, my topic is non-operating room anesthesia. So, the anesthesiologist is usually considered as a superman with super ability and a lot of the ability to do multiple things at the same time. So he is expected to go everywhere and solve all the problems regarding the patient in emergencies to various places and handle the patient where the proceduralist or the surgeon or the physician does his work. So we are the people who manage the other things like the patient and his condition, general condition, and make sure that no problem occurs to the patient and maintain his safety. So with the advent of many super specialty disciplines like interventional radiology, interventional cardiology, radiation oncology, gastroenterology, the responsibility of anesthesiologists have increased manifold. It is quite a challenge to come out of the familiar environment of an operation theater to work in an unfamiliar territory. Because we are usually used to our operation theater environment every day, we work there. So we are quite used to it. So working in a familiar environment is always easy. Whereas going to an unfamiliar environment, there are a lot of challenges we face, which I'll elaborate further as I go. So anesthesiologists need to enhance their familiarity with resources, the personnel over there, the environment, which is outside the operating room. Anesthesia delivery in non-operating room settings should be held with the same high quality standards as that within the operating room. So what's in a name? So there are various names for this non-operating room anesthesia. They are like office-based anesthesia, anesthesia at remote location, outpatient anesthesia, and so on. So where are the places where non-operating room anesthesia is performed? Usually the endoscopy suites, like where there is procedures like upper GI endoscopy, ERCPs are done. Then there are radiology suites, MRI, CT scan is done, interventional radiology, as Vikram very beautifully described just some time back about neuro-radiology interventions. Then cath labs, where different procedures are done, like the elective cardioversion, then radiofrequency ablation, etc. Then burns unit for burns unit dressings. Yes, or for burns dressings, we are often called. Then the dental clinic for extractions, then in pediatric patients for sedation. Then in the psychiatric department, usually for electroconvulsive therapy. Then in the gynecology unit for IVF procedure, that is womb pickup, we are often called for providing anesthesia. So the problem faced in such places, this is the major thing. We face a lot of problems in such places because these places are not used to providing anesthesia regularly. So there are plenty of problems which we face there, like lack of skilled personnel. So we go there, we call the sister, we talk to them. They don't know anything about anesthesia. They usually are like, just a second. They usually do their routine work, that is they assist the proceduralist in doing his work, whereas they are not so much used to assisting the anesthetist. So they lack a skill in helping us in our anesthesia procedures. Then there will be lack of the required drugs and supplies. such as the working laryngoscope won't be there. And the endotracheal tubes of different size won't be there. There won't be a bougie. So sometimes we have to carry all those things with us. Then there will be limited working place. That is, it will be cramped up rooms like endoscopy suite, where hardly you will be having some place to stand. So it will be quite a cramped up place. Then we'll be having limited access to the patient, like when the patient will be in prone position or in lateral positions, and the surgeon will be occupying majority of the place. So access to the patient will be less. In radiology suites, of course, we don't go inside at the time. So we'll be outside and monitoring the patient. So access to the patient becomes quite difficult. Then in these places, there will be quite outdated equipments like old boils machine, because these places usually they neglect anesthesia. Many places I have seen who usually they neglect anesthesia. So outdated equipments will be their old boils machine, non-working laryngoscope, etc. Then there will be usually poor post anesthesia care. That is, once we give the anesthesia and go away from there, the post anesthesia care of such patients, monitoring, vitals recording and all that, and intimating us properly what is the condition of the patient, will be usually poor. Then such places usually have inadequate lighting, because the proceduralists will be looking at the screen. So they usually switch off all the lights. So monitoring the patient becomes very difficult. Example, we cannot see the chest excursions of the patient, whether the patient is breathing properly or not. Then the other challenges or problems which we face is the positioning, that is prone position. That is, we can't we can't have access to the patient for resuscitation when the patient is in prone. We have to first turn the patient, and then we have to continue our work like resuscitation and all. Then sometimes what happens is the proceduralist thinks that he'll do the case on his own without any help from anesthesia colleagues. So he'll start the procedure and suddenly call you. Once the patient starts moving or patient starts screaming with pain, they suddenly call you. This is a nightmare situation actually. When you go there, first point is you wouldn't have done a pre-anesthetic checkup of the patient. You don't know about the history of the patient. You don't know anything about the patient's general condition. Suddenly you're called there. You're asked to provide anesthesia to the patient who is already struggling a lot. You tend to do many mistakes at this juncture actually. Then the other problem is the duration of the procedure is difficult to predict. Some proceduralists finish the procedure very fast. Sometimes the procedure, they abandon the procedure midway. So you would have given relaxants, muscle relaxants, or long-acting anesthetic drugs. Suddenly they abandon the procedure midway. So these, or they may finish abruptly. So these are some of the problems. Then further, unanticipated difficult airway is very challenging and difficult to manage in situations because of all those problems which I have mentioned about. Then coming to indications. What are the indications for non-operating room anesthesia? Usually the main indication is, one of the main indications is pain, which is maybe related to the procedure or other causes. Then many patients may experience claustrophobia, example, in a MRI suit, in a MRI machine. So they are in a small enclosed space, they are taken in, so they feel claustrophobic. Anxiety may be there, panic disorders may be there. Then most common, which we go out to provide non-operating room anesthesia is for children, especially below 10 years. They will be non-cooperative, crying. They will be in an unfamiliar environment, away from their parents. Then movement disorders, seizure disorders. So some people will be having tics or some movement disorders, which avoids the proper investigations like MRI and CT. So these investigations usually require a still patient so that they get a proper imaging. Then in patients with developmental delay, cerebral palsy, and learning difficulties. Now, what are the ASA guidelines for these places where non-operating room anesthesia is performed? Usually there should be a reliable oxygen source with backup supply, adequate monitoring equipment, adequate and reliable suction apparatus and scavenging system if anesthetic gases are used, emergency cart with all the drugs, emergency drugs, then defibrillator, then self-inflating resuscitation bag, AMBU bag, then sufficient space for anesthesia personnel and the sufficient space for the equipment. Then this place should have adequate illumination, battery backup, then appropriate post-anesthetic management as I already described. Now, what are the monitors or monitoring? Minimum required monitors are pulse oximeter, ECG, NIBP, and ETCO2. In remote areas where darkness is present, ETCO2 can be very useful. As I already told, chest excursion can't be seen in dark places, so we don't know whether the patient is breathing or not. You have given sedation to the patient, and you don't know whether the patient is breathing or not. So ETCO2 can be, suddenly patient may go into apnea. So ETCO2 can be very useful. Here, monitors which are used are usually with long extension tubings which may be required, and monitoring may be a particular challenge, especially in a MRI suite. Now, equipment checklist for anesthesia, providing anesthesia in a remote location. So all of us know the acronym SOAPME, that is suction, oxygen, airway, pharmacy, that is drugs, then monitors, and the equipment, that is defibrillators, gas scavenging, and adequate lighting, etc. Now, coming to the choice of anesthesia. So there are various choices of anesthesia for which we there are various choices of anesthesia, that is monitoring. So the proceduralist may call you just for simple monitoring, so that some untoward incident happens, you can take care just for monitoring purpose, or for some sedation. Then there are other some techniques which require regional anesthesia, then total intravenous anesthesia, and general anesthesia. Now, coming to sedation, procedural sedation is defined as a technique of administering sedatives or dissociative agents with or without analgesics to induce a state that allows the patient to tolerate unpleasant procedures while maintaining cardiorespiratory function. So there are two types of sedation, again, conscious sedation and deep sedation. So conscious sedation entails decreased level of awareness that allows toleration of unpleasant procedure while maintaining the ability to spontaneously breathe and protect the airway. Whereas deep sedation, it is an unconscious state during which patients do not respond to voice or light touch. There will be minimal spontaneous movement, minimal or no spontaneous movement, may be accompanied by partial or complete loss of protective reflexes. The degree of safety in conscious sedation is much higher than deep sedation. The patient can easily drift from a state of conscious sedation to deep sedation depending on his or her age, sensitivity to drugs, health status, etc. Titration and adjustment of doses of sedative agents requires skill and experience. Now, coming to the other modality of anesthesia, that is regional anesthesia. Peripheral nerve blocks can obviate the need for deep sedation or GA and can be useful in patients who have significant cardiac disease or are hemodynamically unstable. Example, phrenic nerve block, which can be done in CD-guided pulmonary biopsy, then paravertebral blocks for biliary drainage in case of stricture of bile ducts. Now, coming to the other modality, that is total intravenous anesthesia. So drugs are used intravenously for hypnosis and analgesia. Airway needs to be protected with various maneuvers like chin lift, jaw thrust, or you can use a oropharyngeal airway or a LMA if patient is deeply anesthetized. The example of total intravenous anesthesia is for oocyte retrieval in IVF. Usually propofol and fentanyl are used. Now, the final modality, that is general anesthesia, which is less frequently used. Tracheal intubation is done or a LMA is inserted. Best way to make the patient completely immobile during the procedure, whereas it is invasive and time consuming. Example is an elective cardioversion in a patient with high risk of aspiration. Usually we do rapid sequence induction with intubation in patient with a high risk of aspiration. Now, coming to the drugs. So the choice of drugs depends upon the procedure which is being performed and whether it is painful or not. There is a substantial variability in the response to each drug between individuals. Usually the drugs which are used are like midazolam, fentanyl, ketamine, propofol, ketofol, dexmedetomidine. Then if you give general anesthesia, we do short-acting muscle relaxants like atracurium, then succinylcholine. Or you can, if the procedure is going to be prolonged, then you can use vicuronium also. Now, anesthesia at various locations. What are those locations? So first we'll come to the endoscopy suites. So where UG endoscopy, colonoscopy, ERCP, endoscopic myotomies, esophageal stenting are done. Patients usually who come here are usually uncooperative operative or very sick, especially who are like CA esophagus patients who have come for esophageal stenting and all. The rooms in endoscopy suites are usually small and poorly illuminated. That is one problem. So this is the picture of an endoscopy suite, which is quite well illuminated now, but when the procedure starts, it becomes dark. So the endoscopy suite, continuing with the endoscopy suits, pre-anesthetic assessment. Usually we do the pre-anesthetic assessment to know the age, any anxiety, allergies to any drugs, and the flu status of the patient. What are his blood investigations, electrolytes, any history of gastroesophageal reflux disease, because there is, when we give anesthesia or sedation, there is increases of aspiration, and any cardiac history. Then usually the type of anesthesia is usually moderate sedation with midazolam and fentanyl. If you give deep sedation, propofol may be added. Some cases may require general anesthesia also. So anesthetic consideration in an endoscopy suite is usually airway access. With the use of endoscope, there will be limited or no access to the airway. Usually the proceduralist or the gastroenterologist puts a scope in the mouth. So we, to give a small sedation, usually we put a nasal pumps and give oxygen through that. And we give anesthetic drugs. Sometimes the patient goes into apnea. So again, it will take time for to put the patient supine and or secure his airway and all that. So this problem can be solved with LMA gastro, which has both airway and endoscopic channel. Whereas with respect to position, prone or lateral position will make it difficult for emergency securing of the airway and resuscitation, as I already told. So this is about the endoscopy suits. Now coming to the MRI suits. Usually in MRI suits, there is high magnetic field. These places usually require a specialized and compatible equipment, MRI compatible monitors, MRI compatible probes, and MRI compatible anesthesia machines. Radio frequency noise is a major problem here. So we usually use earplugs or noise blockers in patients' ears. Patients with implanted pacemakers, ICDs, that is implanted cardioverter defibrillators, may not have MRI scans. And one more important thing is you should never take ferrous material in the MRI suite like laryngoscopes, stethoscopes, mobile phones, etc. So this is the picture of an MRI suite with a Draeger Fabius MRI machine. So conduct of anesthesia in MRI suits. Usually the patient is induced outside the MRI room and the patient is transferred to the MRI compatible machine in the room. So usually you need to use MRI compatible monitors or keep the monitors outside the MRI room with the use of extra long cables. Usually MRI compatible monitors are quite costly. And it is very important to keep an eye on the patient, that is chest exertions or any movement of the patients. Then coming to the contrast media, which are most commonly used in MRI suite. So there are, we should take a history of any allergic reaction, any previous history of any allergic reaction in the patient, and complete medical history. Then usually the allergic reaction, if it occurs to the contrast media, the symptoms are airway obstruction, skin reactions. It may go to most severe symptoms like angioedema and cardiovascular collapse. Usually the treatment consists of oxygen, corticosteroids, adrenaline, H1 and H2 blockers, IV fluids, and intubation. Usually we are called outside for providing sedation to pediatric patients undergoing MRI. Usually the drugs which are used are chloral hydrate paraorally 25 to 75 milligram per kg, midazolam 0.025 milligram per kg IV or 0.1 mg per kg IM. Then ketamine, which is very commonly used, 0.5 to 1 mg per kg IV or 3 to 4 mg per kg IM. Then propofol 1 to 2 mg per kg IV, or you can use it as an infusion, 50 to 100 mics per kg per minute IV infusion. Now coming to anesthesia for electroconvulsive therapy. So patients with psychiatric disorders like major depression, mania, schizophrenia, Parkinson's syndrome usually require electroconvulsive therapy. So anesthetists are usually called for providing anesthesia for electroconvulsive therapy. The contraindications for electroconvulsive therapy are mainly raised intracranial pressure, recent history of any cerebrovascular accident, cardiovascular conduction defects, because there is a high risk of arrhythmias during electroconvulsive therapy, then high risk pregnancies. So general anesthesia is used to provide a brief period of amnesia and modify the motor effects of seizure to protect the patient. Now coming to the physiological effects of electroconvulsive therapy. So basically the electrical stimulus which produces a brief period of muscular contraction followed by tonic and then tonic phases of seizures. The cardiovascular effects are immediate. There will be a parasympathetic response followed by within seconds by a sympathetic response. Muscular activity of the seizure and the muscular activity of the seizure and the increased sympathetic activity causes a rise in the myocardial oxygen consumption, as well as it increases the cerebral metabolic rate of oxygen, cerebral blood flow. It increases the intracranial pressure, intraocular pressure, and intragastric pressure, albeit briefly. Usually these patients have often had the procedure multiple times. So if you have a look at their file or their history, you'll come to know how many times the patient has undergone the procedure, any untoward event has happened in the past during these procedures. These old records are quite useful. So we start the ECD procedure by giving glycopyrrolate, placing the bite block, usually hyperventilate the patient with 100% oxygen. And thiopentone and succinylcholine are the commonly used drugs. Whereas the goal here is the seizure, which is of 30 to 60 seconds long. We usually ventilate the patient till spontaneous respiration of the patient returns. Usually after scoline, once the spontaneous ventilation of the patient returns, we usually stop ventilation and put a face mask. The parasympathetic discharge is often followed by sympathetic discharge, which is associated with hypertension and tachycardia, which can be treated with esmolol. So this is the picture of coming to the next location, that is the remote cardiac lab or the cath lab. So the procedures done in cardiac or cath lab are electrocardioversion. So we should make sure that there is a cart with emergency drugs there. Usually the induction drug which is used here is etomidate. Usually pre-oxygenate the patient and give incremental doses of etomidate until the eyelash reflex is abolished. We remove the mask immediately before the shock and confirm that no one is touching the patient. Then we ventilate the patient with 100% oxygen post-shock till the consciousness is regained. Usually in patients with high risk of aspiration, we consider rapid sequence induction endotracheal intubation. Then cardiac radiofrequency ablation. Here we use IV sedation or general anesthesia with endotracheal tube, depending on the patient's comorbidities. Possible need for arterial line setup may be there. Propofol is commonly used. Midazolam and fentanyl are used to titrate during the more painful parts of the procedure, especially during the ablation. Then pacemaker ICD placement, that is your cardioverter defibrillator placement. We are often called just for ICD check-in, in which case we proceed like it is an electrocardioversion. That is, we give sedation and proceed further. Whereas a very sick patient may require general anesthesia with endotracheal tube. These ICD checks are not without risks. We need to be quite vigilant. Now coming to the complications of non-operating room anesthesia. Usually the complications are desaturation, aspiration, laryngospasm, hypothermia. As Prajwal told, hypothermia is quite common in non-operating rooms as well as the operating room setting, but more common in non-operative room settings, because we tend to forget that, or like patient is not adequately covered, or else because of the air conditioning, there are more chances of hypothermia. Then allergic reactions, stridor, and cardiac arrest also can occur. Thank you.
So exhaustive presentation, Dr. Nizamuddin.
Thank you, sir.
The floor is open for questions.
Balakrishna has given some point, right?
Butorphanol and midazolam, I think it's a very good
dose
combination for respiratory depression.
Mild to moderate sedation.
Dr. Balakrishna, you are there?
Yes, sir. I'm there, sir.
Yeah. You said a combination of butorphanol and midazolam, isn't it?
Yes, sir. Sir, I have used this combination for most of my procedural sedation, and I have observed that though the patient goes for respiratory depression, it is transient. Thing is, before we administer sedation, we have to make sure that all the gadgets for securing the airway, preventing tongue fall has to be there on the anesthesia machine. And before we administer sedation, it is better that you start the patient on oxygen in a nasal prongs, either 2 to 4 liters per minute. And incremental doses of midazolam 1 to 2 mg and butorphanol 1 to 2 mg actually gives a wonderful sedation analgesia, in fact. And with oxygen on flow, the patient most of the time maintain a good oxygen saturation of 100%. They don't go for respiratory depression, except in frail patients like elderly, patients who are like obstructive sleep apnea, or patients who are critically ill on multiple inotropes. So in such cases, it is better we avoid this combination. Otherwise, in healthy ASA 1 and 2 patients, it is a very good combination. I've seen over the past 7-8 years, to be precise. Not done any paper on this, but this is my observation. And in fact, many other consultants in Mangalore use this combination for their cases.
Yeah, I think you can try using this. Yeah.
Usually, am I audible?
Yeah, go ahead.
Yeah, I'm usually called outside for MRI sedation. What I observed is, initially I used to give propofol and ketofol. The patients usually used to come out after every 10 minutes. I used to tell the radiology technician to stop the scan, and I used to go inside and used to top up. What I have observed recently is when we give Fortwin before giving ketamine or propofol in a dose of around 0.3 mg per kg, the patient usually sleeps very calmly for like half an hour, 45 minutes, without the need of giving repeated top-ups and pausing the scan which is going on.
I think it's all a matter of giving again a balanced sedation or monitored anesthesia care, right?
Yes.
So depending upon the resources available. So if you have got the best devices and remifentanil or drugs which are very short acting, it would be a good idea to use them. And using butorphanol and even Fortwin and pentazocine will be a compromise. But as long as we monitor the patient and are confident of managing any so-called respiratory depression, hyperventilation, loss of airway reflexes, okay, so we can take correct decisions. And I think when you are talking about non-operating room anesthesia, we are also talking about endoscopy suits. So in the endoscopy suit, where the surgeon wants to pass an endoscope inside, especially upper GI scopy. So one advantage we have got nowadays is the availability of some modified supraglottic airway devices. So these are like gastro LMAs available, and one more brand is available. So surgeon has the liberty of passing the endoscope through a separate opening. And the LMA, modified LMA or supraglottic airway device is able to protect the airway, and a good seal is obtained for ventilation. So these advantages are always there. And of course, NORA considerations always apply. So in terms of preparation, we are not going to neglect the patient just because it is outside of the major OT. So this is one thing I wanted to convey. Anything else?
The only problem with butorphanol and Fortwin is long-acting opioids.
Yes, sir.
Yeah.
The only problem, and I've seen this butorphanol produces quite a bit of sedation. I think that is the only opiate which produces so much of sedation. Just 1 milligram IV. Even when in Ballari we used to give butorphanol through epidural. So even epidural used to produce so much of sedation. That's what Balakrishna must have noticed, that quite a bit of sedation it produced, and that too along with midazolam. Only thing is duration of action. That is one thing with both butorphanol and fortwin. And Bhaskar, in endoscopic procedure, especially ERCPs and all, we are using a combination of dexmedetomidine and propofol.
Yeah, that's the best.
Usually give first dexmedetomidine and then incremental doses of propofol is always used, and excellent procedural sedation with these two drugs. And the use of total dose of propofol also reduces drastically.
Yes.
That is what for ERCPs especially we have found that this combination is very good.
Tadakadu. Kuduku. Tadavarisu means search.
Oh,
sorry, sir. Sorry.
So dexmedetomidine, yes, sir, a very beautiful drug. As you said, dexmedetomidine is the drug we should be watching for and using it regularly. And of course, we are waiting for the short-acting opioids to come into India. I think they are in the process.
Yeah, remifentanil. We have taken up the trial for remifentanil.
Neon people are coming out with remifentanil. They did discuss last month, so that is coming. And for when we talk about non-availability of fentanyl, at least in the private setup, dexmedetomidine should be definitely used. I think it will not be too costly for the patient, and it is very economical with based upon the overall charges. So
actually, we had given this combination of dexmedetomidine and propofol for one of our postgraduates as a dissertation topic. So we found this combination to be very good, actually.
Should be, sir.
Yeah.
So advantage of dexmedetomidine is it provides sedation as well as analgesia without respiratory depression.
Yeah, that is the most important thing. Respiratory depression will not be there, and arousable sedation. That is what is most important. And sleep-like state will be there, and anytime you can, make the patient awake.
Probably as you are telling, frail patients and really patients with history of COPD, and I think we can even have a balanced anesthesia in the form. You can even have straight away an infusion. I mean, a maintenance dose instead of a bolus dose sometimes. That also works, provided we are used to the system. So
the only problem with the dexmedetomidine for procedural sedation is suddenly if the patient requires slightly more sedation, then you cannot give, because then it will be a problem. That's how the combination of propofol also in between. So that helps a lot.
Sir, regarding this butorphanol and pentazocine, that is fortwin, I remember Srinivas sir's study in 2003. It was presented in Orissa conference, sir. What you are referring to, that epidural butorphanol.
Yeah, epidural butorphanol.
Yes, sir. It produces severe sedation.
Vikram was the name.
Yes, sir. Vikram was the name. But the problem is the analgesic efficacy is inferior to other drugs, sir, when compared to, though it produces a significant sedation. I remember many patients would still complain of pain. So probably if we are considering a procedure anywhere where there is some amount of analgesia required, maybe butorphanol might fall short of our expectation sometimes.
Because, we have Sudesh, both butorphanol and fortwin are kappa and sigma.
Kappa and sigma, yes, sir.
Yeah.
So
the receptors agonists.
Yes, sir. They act only at the spinal level. They don't act on the supraspinal. I mean, it's supraspinal is less. Yeah.
They are mu antagonists also.
Yes, sir. Yes, sir.
That's what. You cannot give a mu agonist when you are using these two drugs. Then it will not be effective at all. Like, for example, if I want to add fentanyl, then it will not be very effective after you have given these mu antagonistic drugs.
Yes, sir. Yes, sir. That's one more issue.
Yeah.
And even cardiac patients, sir, somehow it is known to increase the pulmonary pressures. Both of them, they increase the pulmonary pressures as well as the cardiac filling pressure. So I don't know how safe they are, especially when we come across compromised patients. Do you think we
as you said, sir, like if you, as long as we titrate the dosage and ensure patients are monitored properly, maybe we might be safe enough. But that is important. It's better to keep in mind the cardiac effects, side effects of these drugs probably. That is one thing.
Yeah, pentazocine increases blood pressure. It produces tachycardia also.
And pentazocine and ketamine is not a very good combination also, sir.
Correct. Naturally, both will increase the heart rate and blood pressures.
I still remember we used to go to CT room, sir, with the vein circuit and our anesthesia kit. And we used to like give only 0.05 mg per kg body weight of pentazocine sometimes, and then top it up with top it up with propofol that time. Only in pediatrics we had to use ketamine that time and stand outside and monitor. So many times we had to do that. But
so what it means is, in the absence of those drugs, it's always possible to have some balanced analgesia, anesthesia, or sedation.
Hi.
Now that we are blessed with the dexmedetomidine now, definitely
yes,
a good drug. So those days, propofol was not available. Correct. So you are forced to make do with the ketamine, and you are able to maintain the patients without any morbidity and mortality.
Fortunately, sir.
Fentanyl was not available, Bhaskar.
Fentanyl also was not available.
Only pethidine or pentazocine. Butram, just
even tramadol came a little bit late only.
Yeah, later.
Overall. So that's the way it was, and we were able to maintain it.
Sir, sometimes we will be called to give sedation for radiotherapies for children's. We may have to visit them frequently. That is almost on alternate day sittings, they will give radiotherapy. When I was in St. John's, I used to go there to the radiotherapy shoot. There, usually, child used to develop tolerance. That is, child was not going for sleep for the regular dose of thiopentone. So what we used to do is use thiopentone. At that time, thiopentone was available. So we used to use thiopentone and ketamine alternatively. Once thiopentone, and maybe 2 days or 3 days after that, when you go there, we used to give ketamine. Somehow we used to manage that. Otherwise, usually baby used to develop some tolerance, like for the regular dose of thiopentone or even ketamine also. We used to observe that.
Thio is possibility because of its longer elimination of cumulative calories.
Maybe.
Sir, this I have observed in Kidwai also. Same thing what Dr. Srinivas sir said.
Yeah.
Same thing, but we used to give only ketamine. We used to give incremental doses of IM ketamine.
Oh, ketamine. Okay.
Yeah. The first dose used to be usually 1 mg per kg. Then it used to go up. We used to give it almost goes around for 1 week to 15 days sometimes on alternate days.
Yeah.
So we used to give increased doses depending on the response. And at one point of time, we tried even intranasal dexmedetomidine for these procedures. Because then dexmedetomidine was quite new. We tried using intranasal dexmedetomidine because these children will come on alternate days, and there is usually no invasive procedure is done. Only some amount of sedation is given. So we tried that also, but because of the posture, I think they used to put it prone sometimes. Sometimes patient used to be lateral. Dexmedetomidine didn't work very well, especially intranasal. It didn't work very well. We had gone up to quite high doses actually, even with dexmedetomidine, but it didn't work well. So we abandoned it.
Okay. Your dissertation was intranasal dexmedetomidine.
Exactly, sir. Exactly. I changed that topic later. Changed it to intrathecal dexmedetomidine actually later.
Okay.
Intrathecal.
For gynec procedures. But we used that for, I used it for some 10 children, sir. The problem was only with radiotherapy. Changes
radiotherapy.
good amount of sedation and this one, but they used to be put prone. They used to be put strapped down. I think that
They
those
should be
were the
almost
problems.
immobile.
Immobile, totally immobile.
Yeah.
I think those were the problems. So we had to abandon that. We were using that mucosal atomizer device actually.
Correct. You were searching for a device for inhalation.
Yes, sir. Yes, sir. I found that. I was using mucosal atomizer device at that time. There are 3 types. I was using the nasal one actually, but it didn't work out for radiotherapy.
Sir, of the patients, especially for MRI, because of pain, orthopedic patients, they were not able to lie down properly. So, few of the patients we have given an epidural before, and then continued the epidural even in MRI suits, so that they were totally pain-free and they could lie down without any problem. So that also, I think about 4 or 5 patients we had to give epidural before for such patients.
Sir, in the absence of pains, a patient who has no pain, there have been instances and there have been justifications where you don't give an analgesic. You make do, again, you give, for example, midazolam with propofol. And there have been excellent results. Like, there is no complaint of pain from the patient. The procedure was perfect without any motion. Patient would be really under anesthesia, and emergence would also be very convenient without any pain. So how do we explain it? It is midazolam plus propofol only for the patient.
So probably deep sedation, maybe.
Would be as part of deep sedation, because we expect the propofol to terminate the clinical action early.
Only, one thing, Dr. Bhaskar, is that if you give benzodiazepines when the patient has pain, they go for discontrolled behavior. That is really abnormal behavior they'll go in for. Probably, as you said, that combination with propofol may definitely help. But alone midazolam, alone sedation, when pain is there, you will have a violent patient.
That's restlessness and analgesia. But it's like midazolam followed by propofol, and once the patient is under both combination of 2, and it's not the analgesia component, it's the depth of anesthesia that is attained, and that makes the procedure smooth. So those things have also been described, where we really don't use an analgesic specifically, fentanyl or midazolam or any other opioid.
But then I think maybe the dose of propofol may be increased. Increased requirement will be there because you are not providing analgesia through an analgesic. You're trying to provide analgesia through sedation, sedative drugs. Probably, maybe.
Because I have tried this combination. And patients were comfortable in the sense recovery could still be attained early. So it would have gone up by about 10% to 15% only as a top-up or infusion of propofol.
Okay.
So practically, yes, theoretically speaking, these are the controversies, but practically they have been found to be useful. It doesn't affect the recovery aspect also. Maybe we would be forced to continue post-procedure oxygenation instead of about 5 to 6 minutes. It could go on for about 7 to 8 minutes. And patient will be totally back to awake state.
Yeah, one can use non-opioid analgesics along with these drugs.
Yeah, that's always...
like a non-steroidal anti-inflammatory drug combination with midazolam, propofol. Probably yes.
In addition, surely.
So, but today both lectures were excellent. Really
excellent. Yes, sir.
Nice. Congratulations to both Nizamuddin and Vikram. Really enjoyed. Though I was so tired, and I don't feel tiredness now because I drove all from Chelkere to Mysore.
So both were compact and extremely
very nice, and they stuck to the time.
Yeah,
it is very, very important. 30 minutes means 30 minutes. I was just observing. Very nice lectures, very comprehensive, very nice.
Thank you, sir.
So, any other questions? So Dr. Kuchel Babu sir, he says, so thank you. I was streaming this live on the YouTube.